Now we have reached our third and final symposium. For Symposium 3, we will be carrying out another case-based discussion on enhanced respiratory support in respiratory failure, high-flow nasal oxygen, non-invasive ventilation, and beyond. To moderate our third symposium, and as well as to share her views on the topic, I would now like to invite Dr. Dilesha Vadasinghe, consultant pulmonologist and senior lecturer at the University of Kelaniya. Madam, over to you.
Thank you, Shavindi. To conduct this very interesting symposium, I would like to invite the three speakers, Dr. Afla Sadikin, consultant respiratory physician, National Hospital of Sri Lanka, and Dr. Dilshan Priyankara, consultant intensivist, National Hospital, Colombo, and Dr. Anushka Mudalige, consultant intensivist, Teaching Hospital, Colombo North. So welcome all to this last symposium on enhanced respiratory support and in respiratory failure. Let's begin with our first case. Right, so the first case is a 45-year-old man who was admitted to the emergency department with a 5-day history of cough and fever. He has a background history of type 2 diabetes, high blood pressure, and CKD stage 2. He complained of right-sided pleuritic chest pain, and he produced rusty-colored sputum. On arrival to the ED, he was breathless and complaints of muscle ache and joint pains as well. So temperature was 38, conscious rational, respiratory rate 32, the saturation on room air was 89%, and there was right basal crepitation with reduced breath sounds. Pulse rate 110, blood pressure is 110/70, and the rest of the examination was normal. So this is the chest X-ray, and we have the blood gas reports as well. So I would like to ask Dr. Afla whether he would like to interpret the X-ray results for you.
Thank you very much. Thank you very much for that kind introduction and inviting me for the case discussion. Now, since we are talking about oxygenation and ventilation in this session, so we'll be skipping the basic or the initial part of the community-acquired pneumonia or in related to the medical condition, the initial part of the management. So we have got a patient who is having with a febrile illness and with respiratory symptoms, who is fully oriented and he is hypoxic. So naturally we think of chest condition, and with this chest X-ray showing there is a right mid and lower zone heterogeneous opacity, and right extreme maybe increase homogeneity, and now the left lower zone may appear as heterogeneous opacity over there, but we must when you look at the chest X-ray, you must always remember all these patients are acutely ill and the X-rays are taken in the emergency setup, so there will be issues with in an AP view as well as with the exposure. So yes, we have to go with the clinical findings first, along with the chest X-ray finding and evidence of a consolidation on the right lower zone. And on the in the ABG, if you look at it, the pH is 7.3 and he is hypoxic with a PO2 of 58. However, carbon dioxide is 32, and he is having a lactate of 1.7. So we have a hypoxic patient with acidosis.
So this is a patient with community-acquired pneumonia coming with the type 1 respiratory failure. And the most probable diagnosis, as we know, would be a community-acquired pneumonia. So having given that history, so what would you, how would you manage this patient further? in terms of focusing more on the oxygen support?
So we must not forget the initial part of the management with the oxygenation and the hydration and the IV antibiotics. So I'll be talking about oxygenation in the next couple of minutes. Before that, I would just want to highlight this since we are we have the microbiologists also on board, and about this dose to antibiotic time. So now the recommendation or the well accepted thing is having the first dose of antibiotics within 4 hours of admission. So and we all know that in UK and all they are very strict on this now, and there are some centers and some provinces where they are looking at giving the antibiotic at the GP level or even in the ambulance. So when it comes to oxygenation, what we have to look at it now, this patient is saturation is 89, and where we have to have a target saturation. Now remember, we heard about the oxygenation, how important it is. It has to come on a prescription. So we know that we don't have a we don't have a standard practice as such in Sri Lanka. I think we have to take this into account. So I would request and hope our current president, Dr. Niranjan, will take this matter up with the relevant authorities to come this as a document to practice in our hospital practice. So with the appropriate documentation, we all should have a target saturation for this patient. So that is, since patient is acutely ill and there is no evidence of carbon dioxide retention, so we can have a target saturation more than 94. And when it comes to oxygenation, selecting the appropriate device and the proper flow rate is another important thing. So also when we prescribe and when we administer oxygen, remember, when we administer oxygen, that means like on the prescription basis, there should be a proper monitoring. So the monitoring also has to be on documentation. So this is the British Thoracic Society guideline. I'm not going into detail how the oxygen administration should be followed up on the not only just targeting the saturation, also according to the so it's quite small letters about the oxygen requirement and the carbon dioxide retention. On that basis, how we decide the oxygen device and the flow rate accordingly. So if you take the oxygen delivery devices, the choice of oxygen delivery device depending on the degree of hypoxemia. So we have a low flow oxygen delivery system and we have high flow oxygen delivery system. So the usual in a patient who is not severely acutely ill, we for the achievement of oxygen more than 94%, we can use nasal cannula or even simple face mask. And when we use a non-rebreathable mask, if we are using common, but we use is a one-way valve where you can go up to 10 to 15 liters per minute, where you can achieve the oxygenation more than 90%. But today we will be talking more on this high flow oxygen delivery system. So in that, the most common thing what we use is a high flow nasal cannula. So if you take the ERS guideline about this oxygenation when it for those people who need acutely, like for this patient. Now there is there are some studies they have tried to find out, or they have tried to prove that the use of high flow nasal oxygen along with conventional oxygen treatment. So however, the ERS recommendation, they say that if there are acute hypoxemic respiratory failure, so the high flow nasal oxygen is they are recommended over conventional oxygen treatment. So what about NIV? or non-invasive ventilation. We'll be going that little later, and however, again the recommendation is the use of in this paper that high flow nasal oxygen is recommended over non-invasive ventilation. So if you take high flow nasal oxygen, so now if we saw this device quite commonly and frequently during the COVID era, and this device is basically generate a flow, and also it blends the air with an humidifier and by using a nasal cannula. So it can generate a flow up to 60 liters per minute, and also you can titrate independently the FiO2 based on the oxygen requirement. So even you have a high flow and humidification, we can improve the functional residual capacity, and also we can improve the mucociliary clearance secretions. By doing this, we can reduce the work of breathing. So which is very important for those patients who are having hypoxic respiratory failure with an increased work of breathing. Yeah. So now, when we deliver oxygen, as we saw from the previous slides, it appears that high flow nasal oxygen is far superior and more recommended. However, if you take the context of the scenario, in the sense that the feasibility of or availability of high flow nasal oxygen, it's not so easy to administer oxygen in a high flow nasal oxygen pattern. So, but what we see is commonly using the Venturi mask, or sometimes with the increased work of breathing, use of non-invasive ventilation, there will be a opportunity of delivering oxygen and to reduce the work of breathing. So for that, there had been few studies done, and they say that though the non-invasive ventilation can be used, and especially for those patients, if you are having using the helmet mask, the mask or the interface, in those patients, they can be more useful for certain patients. However, there is no optimal ventilator strategy to set up for these hypoxemic respiratory failure patients to improve the oxygenation. So what is important is you need to have an early identification of non-invasive respiratory support if you to identify the failure. If not, it can be decremental for these patients.
Okay, thank you, Dr. Afla, for that. And now, seems that our patient started on 15 liters, not improved, and now we have commenced on nasal high flow therapy, and the blood gas has the pH is within normal limits, PCO2 is normal, PO2 has become normal, and the bicarb levels are within normal limits as well. But the thing is, the respiratory rate here has still, it has come down, but it is still quite high. So with the slight starting on nasal high flow therapy, and patient is improving, but still with the high respiratory rate. Now, as Dr. Bandhu said, we need to think where we are going to place the patient. Are we going to send the patient to the ward? Are we going to send the patient to HDU? Are we going to send the patient to a ICU? So can I ask Dr. Anushka about her thoughts on where to place, how can our tradies guide themselves in where to place the patient in this setup?
Okay, thank you. Hello, everyone. So, yeah. So this patient, now when we talk about where to keep a patient, there are 3 levels of patient care, level 1, 2, and 3. Level 1 is ward-based, level 2 is HDU care, and level 3 is ICU care, where there is one-to-one nursing. And so for a patient to come to level 1, he needs invasive respiratory support, that is intubation and ventilation, alone or 2 or more organ failures. But those are the indications for level 3, sorry. And for level 2, it should be 1 organ failure. But saying 1 organ failure, if it's respiratory, intubation warrants the patient to go to level 3 by itself. So you don't have to wait for another organ to fail, or just having a respiratory failure alone is enough for the patient to go into ICU. But now this patient, of course, as you can see, let's assess this patient again. So this patient is critically ill. I think everybody agrees on that, right? Yeah, critically ill means any organ, there's a dysfunction. So any patient who is critically ill has a chance of dying, 50% more than a non-critically ill patient. So the killers, the acute killers, which we are concerned when it comes to intensivists, when it comes to ICU, A would be the airway. Airway kills first. So if I were to see this patient, I would go and assess his airway first. So this patient, if this patient is able to maintain his airway, that is talk, and any absence of signs of airway compromise, I would be happy. So in this case, I don't think, Dilisha, there is no airway problem in this patient. Breathing. So it's look, listen, feel, or you do inspection, palpation, percussion, and auscultation to see these things, whether they are present here. So the respiratory rate, whether it's inadequate or over, that is a rate of more than 30, I would be concerned. But now this patient's rate, which was earlier 30, over 30, has come down a little bit. And the work of breathing. So work of breathing means how much your muscles are working, your diaphragm, your intercostal muscles, accessory muscles. So you look at the patient and see how he's doing. Now, it was not mentioned earlier whether the work of breathing was excessive, but later on it was mentioned it's moderate. So I was hoping that with the high flow nasal oxygen, maybe it has come down. But I would keep an eye on that. It's a very important determinant to see the next step of management. And yeah, and there was reduction, or there were crepitations on the right side. If with improvement, this would go down. If there was reduced air entry, that would come up. So I would look for these also. So it's actually a trend that I'm going to look for, rather than just going and seeing this patient and deciding on that point. And also, I would look at the numbers. So saturation is important. Also, if I can do a PO2 and a PCO2, that would also be helpful. So I've seen the PO2 has actually gone up. And the PCO2, he was still hyperventilating. The carbon dioxide was washing up. So the hypoxia is not completely reduced, but seemed like he was doing okay. So at this moment, will I intubate? Let's see how it goes. So then the third killer is circulation. After breathing compromise, circulation will kill you. So hypoxia, how does it contribute to circulatory abnormalities? Well, it will cause a tachycardia. And it might, if you're in sepsis, you might go drop your blood pressure and go into low perfusion. I would check for these. If you remember, the patient was very tachycardic earlier, but later on, the heart rate also dropped. So seems like our therapy is working. And the blood pressure was, he was hemodynamically stable. And dysfunction. So the third killer is dysfunction. That is your brain. So with hypoxia and hypercapnia, your conscious level will go down. But here, of course, that was not the case. The GCA was actually good. So seems like the brain is perfusing well. There is no hypoxia. So I'm okay with that also. And other things related to hypoxia is everything else that you can see. So patients who are hypoxic, if you have seen them, they're very restless, they are sweating, they do not comply with what you say. So look at that overall also. Don't restrain him. He's being so because of the hypoxia. So this patient again was not, getting restless and all. And there was no sweating. So I'm okay with that. Now, as an intensivist, I use a lot of ultrasound, and I can do a bedside ultrasound in this patient, and this is what you would initially see. This is called, here, is a consolidation, the C profile that you see. This is the diaphragm, and this is the liver. So in our patient, actually, we saw something like this. So it actually has progressed to a much kind of, you can actually see the air bronchogram inside. And when some cases, you might see associated effusion as well here with the collapse of the lung. So as earlier also mentioned, bedside ultrasound is very helpful. I would also like to exclude a pneumothorax with the lung sliding. I would look for lung sliding, a barcode sign, and lung point to exclude a pneumothorax in this patient. And also a B profile, a wet lung. This is common in pulmonary edema as well as even in severe pneumonias. You would see the lung getting quite wet. So these are the things that I would look for.
Thank you, Anushka. And also now, not all our patients with community-acquired pneumonia would improve with the initial management and high-flow nasal. So we need to look at our patients to see when they are failing on the high-flow nasal oxygenation. So Anushka, can I ask you again regarding what are the things we look for failure of high-flow nasal oxygen, and what are the indications for the next escalation step?
Yeah. So for hypoxic respiratory failure, high flow is, as I said earlier, high flow is kind of the first kind of the recommendation. For NIV, the recommendation is a little bit less compared to high flow. So after failing high flow, there's no point, I would say, to go into NIV and see. It's actually, you would have to intubate this patient. Threshold for intubation for hypoxic respiratory failure is very low. You would intubate quite quickly compared to hypercapnic respiratory failure. So these are the indications for intubation in a hypoxic patient. Apnea. So the patient has exhausted and now gone into apnea, or tachypnea, persistently increased respiratory rate of more than 30 or even higher than that, and your level of consciousness is dropping due to the hypoxia, maybe due to hypercapnia. Now the patient is getting exhausted. You see that. Early he was breathing recklessly, now it's slowly slowing down. And the patient is now getting hemodynamically unstable. You don't want two systems to go down. You have to get control of one system at least. So the easiest system is to get hold of is respiration. You can't control hemodynamics that well. When you intubate, you take hold of the respiration. And then also the oxygenation has not improved and the carbon dioxide is not improving. Especially remember this in hypoxic patients. Okay, that has not come up. Actually, the most important thing I would say, especially this came up with corona, is the patient-induced self-inflicted lung injury that you'd see. So these patients will take deep breaths in. So tidal volumes will go up to 8, 9. And when that happens, that causes something called self-inflicted lung injury. Apart from the pneumonia, the patient with his breathing mechanics is causing injury to himself. So that will cause long-term adverse outcomes. To prevent this, they recommended going for early intubation in these patients. So that, I would say, would come like a priority in type 1 respiratory failure. Yes, and as earlier asked, I think, sir, you said how to assess this hypoxia in the ward setting. So PO to FiO2 ratio has been implemented as a good investigation to do, provided that you have adequate blood gases. So we used to do this, and the ratio of less than 300 indicates kind of a severe lung injury. But saying that, with the corona, the worldwide, the corona pandemic, not everybody was able to do blood gases, and it was hectic kind of doing blood gases over and over. And even with the PF ratio, there's no number as saying at this number you have to intubate. It's actually the trend you're looking for. Anyway, a number of less than 300 said it's kind of going into severity. So instead of PF ratio and doing blood gases, you can do saturation FiO2. I do this a lot. I don't do blood gases on all my patients. I look at the saturation and I look at the FiO2 the patient is on. That would give me an idea. 50%, 90%, on 50%, 90% saturation is not good. Like that has gone into my mind now because I've seen it already. 25% saturation, 99, that's a good lung. So it's kind of, you don't have to do blood gases all the time. You can get an indication of your oxygenation like that. Also, they have used this oxygen saturation index, which I'm not going to talk about. But the ROX index, as you said, sir, yes. So again, they looked at the oxygen in the hypoxia, that is the saturation divided by FiO2. and work of breathing, both together, because hypoxia causes increased work of breathing, as well as type 1 respiratory failure causes hypoxia and increased work of breathing. We have to consider both of them. So they have combined that and given this ROX index, and they have seen if it's going down, that's an indication of failure of high flow nasal oxygen. If your patient is on high flow and if your ROX is going down, that tells you that this patient needs early intubation. Again, there's no number as such to say. You look at a trajectory. And as Amanda said earlier, if your patient is going on more than 50 liters of oxygen and more than 50% or 60% of oxygen on a high flow, that means he needs critical care. Yeah.
Okay, thank you.
I would put him on a HDU.
Okay, thank you very much. So with that insightful thoughts, and I know all of you are burning with questions to ask about type 1 respiratory failure, high flow, and non-invasive ventilation, but we'll save the questions for the end of the presentation, and we'll go to the next case where it is a so this is a patient who is 52-year-old man, who is a heavy smoker, who presented to the emergency department with progressive worsening dyspnea for 3 days. So this is his vital parameters, the blood gas and the chest x-ray. In the interest of time, I will just move to Dr. Afla by asking the question, can you please interpret the results plus tell us how you will approach the management of this patient?
So we have a patient who's not previously diagnosed with any respiratory condition, but he's a heavy smoker, and looking at the parameters with the increased respiratory rate and low saturation, with the hemodynamic stability apart from heart rate being 114, his chest X-ray looks hyperexpanded lung fields with flattening diaphragm, and also the shape of the heart, which somebody can call say is a tubular type of heart, and with that chronic lung disease, most probably an obstructive lung disease is a possibility. And looking at the blood gas, he's clearly acidotic with a PCO2 being 59. He's hypercapnic, and with lactate also 2.8. So this is patient is having a possibility of a chronic obstructive pulmonary disease with a type 2 respiratory failure, that is hypoxemic and hypercapnic respiratory failure.
So, so this is the interpretation of it. And then would you start non-invasive ventilation? So everybody knows hypercapnic respiratory failure is non-invasive ventilation. So would you start non-invasive ventilation straight away, or is there anything else you would do before?
Yeah. So it's a very good question for somebody who is in the emergency. Now, when you see a blood gas or with a patient who is having this kind of X-ray, you think, okay, straight away I will go for non-invasive ventilation. Having said that, what this patient need is optimization of the medical management. So we must never forget that. So when it comes to optimization, it's the oxygenation. So there are different school of thought about oxygenation, but however, the recent recommendation and the recommendation for oxygenation is you have to have the target saturation, as I was talking about in type 1. Here the saturation target should be 88 to 92. So apart from that, the rest of the bronchodilation with nebulization along with steroids and antibiotics is empirical antibiotic use is important. And also we must look for the reason for the exacerbation, because we all know these patients with the exacerbation, they can have concomitant or precipitating cardiac event. So looking for underlying ischemic event also is important by looking at an ECG or even doing blood for troponin I along with the history. Now, another important things what we need to look at it from the patient point of view is whether this patient has had any previous admissions, whether this patient had any previous ICU admissions, because it is important for the long-term management, and also whether this patient has had any previous non-invasive ventilation, or what type of oxygenation and what type of rehabilitation program whether this patient was subjected. So that means the previous diagnosis, if we can go through while we are doing this medical management, it is important to take a decision on whether to go for next step of management, that is non-invasive ventilation.
Okay, thank you very much.
Yeah, very good question. So it's always important to understand when now you ask the oseltamivir, use of oseltamivir, in that case we are suspecting a viral infection, because it is quite common the exacerbation can be purely non-infective. If it is infective, it can be viral or it can be bacterial. But traditionally what we do is we think it is bacterial and we give antibiotics. But in this case, I would personally like to go through the history. So if you have any clinical evidence from the history, like maybe a small child at home or having a flu-like symptoms, yes, then I will consider.
Okay, thank you very much. Now, so we have repeated the blood gas after 60 minutes of medical management, optimal medical management. So this is very important. I want to highlight all the trainees. We don't do blood gases very frequently. So the guidelines suggest after 60 minutes of initial medical management, you do the blood gas, and then you decide on whether we are going to start the patient on non-invasive ventilation. So here we can see the work of breathing. The respiratory rate actually is more or less the same or slightly increased. Oxygen saturation has improved somewhat, but still high respiratory rate, tachycardia, blood pressure is same, and the conscious level is same. So this is the blood gas what we have repeated. So we can see here still acidotic. Oxygenation has improved a bit, but his carbon dioxide level has gone up slightly. So moving to Dr. Anushka, I will just ask how are we going to proceed from this place onwards?
Yes. So do you think this patient is improving? No. So that's the important thing, to look at the trajectory of the patient. So we need to do something. What do we need to do to this patient? Start NIV, right? So the European Respiratory Society and the American Thoracic Society both have issued this guideline. They recommend that bi-level NIV for patients with acute respiratory failure leading to acute or acute on chronic respiratory acidosis. That is a pH of 7.35 due to COPD exacerbation. This is a strong recommendation. Mind you, this is the first time of this symposium that we are actually giving, apart from antibiotics, I think, a strong recommendation. So also they recommend a trial of bi-level NIV in patients considered to require endotracheal intubation and mechanical ventilation unless the patient is immediately deteriorating to a level that he needs intubation. Again, a strong recommendation. This we did not say in hypoxic, type 1 respiratory failure. We do not do this. We go ahead with intubation. But here they have given strong recommendation to start NIV. So I think this is very straightforward. If the take-home message is in type 2 respiratory failure, put them on NIV. Yeah. So yes, I got confused a bit. So if I went through all the literature that was done, and there were loads, mind you, loads of literature on this, and they have all shown that there are so many benefits. I'm just putting them on like this to see. These are few things that I took screenshots of, and then I got tired, and then I just went through the ERC and just read what they have said. Now, the main benefits they have looked for, but to make that recommendation early is this mortality. Now, if you see here, those compared to standard care, NIV, and here is standard medical care. If you give NIV for 463 patients, 41 of them would die. And if you give standard care for 368 patients, 73 of them would die. If your pH is less than 7.35 that I mentioned, yeah. So it's statistically significant. You can reduce mortality if the patient's pH is less than that by giving NIV. But if you do that, now that part is actually cut off here. Yeah. Who are not acidotic. Here, if you have, now the patient's pH is normal, but the carbon dioxide has gone up. In those patients, in 35% patients, one will die with NIV. And in 37 patients who were given standard medical care, that is not NIV, two would die. So that is not statistically significant. So if the pH is not dropped, they don't show a mortality benefit. Okay. And if you compare mechanical ventilation of 101 patients who had compared to patients who had NIV, 10 would die. Of 104, 10 would die. So compared to intubation and non-invasive ventilation, there was no difference. So you can see you can prevent intubation and still have the same mortality, provided that the pH has gone down in those patients only. Do you get the indication for NIV in COPD? Yeah, okay. So then they also compared intubation and patients with acute respiratory failure who are acidotic, NIV compared to standard medical care. Out of 565, 71 got intubated. Out of standard care, 470, 180. So that is statistically significant. You can prevent intubation by giving NIV in these patients. Who are not acidotic, you can see it's crossing the bars. There is no significant difference. So that's the point I wanted to make here. So apart from that, what are the other advantages of having NIV on COPD patients? It will reduce respiratory rate and increase pH in 4 hours. So see how quick it acts. And it reduces the dyspnea level. It reduces the need for intubation. It reduces the stay in ICU and hospital. It reduces respiratory and non-respiratory infections. It reduces hospital readmissions, and it is quite cost effective. And implement considerations. So they have given other two recommendations. That is, bilevel NIV should be considered when the pH is less than 7.35, when the PCOT is more than 45, and the respiratory rate is more than 20 to 24, despite standard medical therapy. And bilevel NIV remains the preferred choice for patients with COPD who develop acute respiratory acidosis due to hospital admission. During hospital admission, there is no limit for pH below which trial of NIV is inappropriate. If your pH is 7, that doesn't mean you have to intubate. You can give a trial of NIV, provided that you monitor the patient very safely, so that you won't miss that intubation point. So it's quite safe even in severely ill patients, but you have to monitor these patients.
Okay, thank you, Anushka, very much. Right. Now, when we are going to start NIV, is it just as simple as put the patient on NIV, or are there any more things we need to consider before starting a patient on NIV? It's very important, because we just should not, as clinicians, just tell the nurses start on NIV and just leave. But there are various steps which is very, very important for us to consider. Can you just let us know what they are as well, Anushka?
Yes. So communication is very important. You have to tell the patients that you're going to do this, because this is actually a claustrophobic procedure that you do in the ICU. So reassure them, tell them that you're going to put them on, and it's going to be scary, but still you have to do it, and we'll have a trial on that, and tell that it's going to make a pressure imprint on their face also. And you have to hydrate this patient before you put them on on NIV. Any positive pressure would cause a reduction in the venous return, and it might cause a reduction in your blood pressure. So make sure your patients are well hydrated. Anyway, these patients are dehydrated, and so make sure your mask is the correct size. There are various sizes of mask, and you have to find the appropriate size. If you're using, 2 limbs, there should be no holes on the mask, and it should be cushioned so that it won't cause pressure sores. And find the appropriate FiO2. You know your target saturation for carbon dioxide. It's for oxygen in COPD, it's low. So target very low oxygen to achieve that. And start at low pressures. I will discuss that later. And so here we actually started with the EPAP of 5 centimeters. That is the low pressure. And the IPAP of 10 centimeters. That will work above that EPAP. So that will give the drive for the tidal volume rise. And the target tidal volume for any patients for that instance is about 6 to 8 ml per kg per ideal body weight. So it will indicate the tidal volume. Just see with that IPAP whether you're achieving that. Yeah, and at this point, you would also to have a talk about escalation and ceiling of care, because outcome of COPD patients are little poor when you escalate treatment. So you might have to have a chat with the family as well at this point.
Okay, so this is what happened after, just like Dr. Anushka highlighted. In our patient, we started on NIV and then the blood pressure dropped. So the patient was not properly hydrated before we put them on NIV. So we need to think about that as well. Also remember to look at the blood pressure parameters in your patient before you put on NIV, because once you put on very high PEEP levels, the venous return reduces and the blood pressure will drop further. So you need to be very careful about the blood pressure as well. In addition, we need to exclude pneumothorax in this patient. So our patient's chest X-ray did not have any pneumothorax, but we need to look carefully not to miss a small pneumothorax in our patients. Right. So after 1 hour of NIV, we know that most of our patients do improve, but unfortunately our patient is not improving. The PCO2 is increasing. So the oxygen levels are okay, but the acidosis persists. So Anushka, again, what would you consider in this patient, and what would you think about in optimizing this patient further?
Yeah, one thing is it could be that the NIV is not working, but there are so many other reasons why this could be happening. So just make sure that the tidal volume is adequate. If it is not adequate, you can go up on the IPAP about 2 to 3 centimeters every 5 minutes until you get that tidal volume. And also check for leaks. This is the main reason why most of the time our non-invasive ventilation does not work. The mask is not the adequate size. It's not covering the nose and the mouth tightly. And sometimes they are on NGs, and that is a point where it leaks. So make sure that it's appropriately fixed, and make sure that there are no leaks in the limbs and it's actually working properly. And so after doing all this, again, you can wait a little and see how the patient is doing. The work of breathing should come down. The respiratory rate should come down. The patient should be more comfortable. The conscious level should improve, and you can do a blood gas later on to see whether there is actually improvement in your carbon dioxide.
So after about 4 hours, we have done the basic optimization. So that is the basic optimization we do in a ward. We check for leaks. We check whether the mask is fitted properly. We look for whether the tidal volume has reached. But still, after 4 hours, our patient still does not improve. The blood gas does not improve actually, and the pH is remaining low. So at this point in a patient who has been on NIV, what are the further troubleshooting we should be doing, and how to identify some advanced troubleshooting mechanisms? So I will just turn to Dr. Dilshan for that.
Thank you, Dilisha. Now, this is a very common call that we get, especially from ETU. I'm at the National Hospital, so we get calls from ETU, from Dr. Landroll, where he asks whether you are fair or dark. So, he asks, you are fair, no? Right? So that means he needs a bed. So I'm wondering that this patient is going to come to the ICU probably because he's not responding to your initial medical management as well as for your NIV therapy. Now, if you see the blood gas, you have gone up on the IPAP, and still remains hypercapnic. Oxygenation fairly okay. Lactate have gone up, I don't know, probably maybe because of your salbutamol or maybe because of perfusion related. So, can I have a pointer? So there are few things that you need to look into whether your NIV is doing the job. Most of the time what we do, we put the NIV and we go, and we don't know what's happening with the patient is breathing. Sometimes the patient is drowsy. You are happy because patient is not dyspneic, but actually patient is drowsy because the carbon dioxide is going up. So you need to look at the machine as well. If you know you treat the patient, but at the same time you need to know the machine as well. So leaks, Anushka was highlighting about the leak. It's a very common problem because of non-fitting mask, face mask, that the patients are not ventilated well. So in all these NIV machines, there's an leak limit that you allow, where you can't have a zero leak, so no leak. So usually there is a leak, but it should be right. So if you see this, the ventilator, the pressure volume loop, most of the machines this gives, even the smaller machines will tell you the pressure volume loops, and you see, you see there's a gap. So this is the inspiration and the expiration. This is the expiration. So the expiratory limb is not completed. So this air is leaking. So you know from just looking at this graph that the air is leaking. So then you have to know that my patient is not ventilating well, so you need to adjust this. So the commonest problem I would guess is this mask. Then so you all know, so the mask should not be so tight. So at least your 2 fingers should be able to go through the straps. Then the other thing is the air trapping. A lot of these emphysematous patients trap air, and especially with NIV. So what happens when you give large tidal volumes, and they have problem with expiring this gas? So some of the gas will remain inside the lung. So see, this is a flow volume, the flow time curve. You see the inspiratory time and then the expiration. So the expiration is not complete here. So before the patient exhales completely, the next breath starts. So there's a bit of gas trapping inside. So the next problem that you get when you gas trapping, your carbon dioxide will go up. So the hemodynamics collapse because your intrathoracic pressure goes up, blood pressure drops, and a patient, sometimes you see patient goes into arrest. So when they arrest, what do you do? Put a tube in and pump air. So you should not do that. You should allow the carbon dioxide to go out. So this is another problem that you see, the gas trapping. So you should allow more expiratory time. In NIV, in a spontaneous breathing patient, that what you should adjust is the expiratory threshold. So you allow more breathing. So if you look at this, this is a scalar. So if you look at the scalars and the loops, you can get an idea what's wrong in the mechanics. So what happens next is the ineffective triggering. So suppose you get a breath in and your air traps in. So the breathing machine is a negative inspiratory machine. So you create a negative intrathoracic pressure that creates the expansion of the alveoli. So if you have more air, if your intrathoracic pressure is high, they need to create more negative intrathoracic pressure to take in air. So so some of the breaths are ineffective, cannot trigger the ventilator because you are tiring and you need to create a large negative intrathoracic pressure. So some of the breaths are not delivered. So if you just look at this graph, you see it. If you don't look at it, you will not see it. So the other disadvantage of air trapping is ineffective triggering. So those are the things that you should look into when you are troubleshooting the patients who are not improving despite your optimal therapy and who are on NIV.
Thank you very much, and I think it must have his talk must have solved most of our doubts and given us more things to look in our patient on NIV. Now, this patient after 36 hours has improved, and the pH has come back to near normal, and PCO2 is normal. PCO2 has come down, not to normal, but closer to the normal levels, and the bicarbonate levels are still high. Lactate is normal. So this patient, are we going to keep this patient on NIV in the same settings, or what are we going to do after the improvement of this patient? I'll turn to Dr. Dilshan once again.
Yeah, so first thing is look at the patient clinically, whether he is clinically better. Patient will tell, I'm better. right? Patient will tell, my breathing is much better, right? You see it when if you have seen the patient, quite frequently or from the admission, so you see the patient's clinically better. Then only you look at your numbers. So the number that we go by the blood gas, because this patient is on NIV. So looking at the blood gas, the pH has improved, carbon dioxide come down. And so he's a chronic retainer. It's very likely he's a chronic retainer. So someone would argue, no, see, P50 is still high. I want less of carbon dioxide. So why you want lesser carbon dioxide? But he's quite fine with this CO2. He was fine with this CO2. So the other thing is, if you lower the carbon dioxide further, when you remove the NIV, the compensatory mechanism from renal. So it will take time. So then he'll go back. So best thing is try to find out what's his baseline carbon dioxide, what he's used to. So so fairly, you're coming down on the supports, if the same supports, but your gases are improving. Now I feel, so you try to wean him off, whether I can wean him off the NIV, right? So if the patient is rapidly improving, your numbers are getting better very quickly, so you can stop the NIV abruptly. But if you're slow to improve, then you can come down on the supports. Support is the IPAP basically. So you come down on the pressure supports at intervals that you prefer and see how he does, right? Sometimes you may not need to do the carbon dioxide as well, because sometimes the people tend to treat the number, not the patient, right? So sometimes patient is fairly okay, they put a mask on, no, your CO2 is high, you need the mask, so you don't do that. So, right? So it's a combination of all. So see the patient, see the numbers, and de-escalate your therapy. And also at the same time, when they are off the NIV, monitor them. Don't think when they are off NIV, they're going to do well. I mean, they can deteriorate, right? So always monitor them even when they are off NIV.
So the patient is improving, and the patient was weaned off the NIV to a Venturi mask, and hemodynamic is stable, no signs of infection, and is ready to step down to a ward and then planning discharge. So for the audience, this is for the audience. So your patient is on optimal medical management supported with NIV. We have asked in the history, he has received NIV in a previous episode as well. So when your patient is being discharged, what else should you consider? You saw the blood gas, it was not perfectly normal, but it was near normal. Right? So what else should you think about a COPD patient or a patient with type 2 respiratory failure on discharge? Any thoughts?
You can ask from the audience.
Yeah, for the audience. Why don't one of our senior registrars think of answer it?
Good that still they are awake.
Yeah. Especially in Colombo, in Valisara, they should be able to answer what we are going to do. Ruben, why don't you give us your thoughts? Sorry, I have this habit when I'm teaching for medical students in asking, pointing out people. So, yeah. So we need to think about, in a type 2 respiratory failure patient, previous episode of NIV, whether we need to put them on home NIV, whether the patient would need home NIV. And also here in our patient, the blood gas was 60, the PO2 was 60. So maybe he might not need home oxygen, but then should we work this patient up for home oxygen? So the saturation target was maintained, but not. So there are clear evidence to tell that. So despite encouraging exercise, a healthy lifestyle, immunization, stopping smoking, we need to think about long-term oxygen therapy. Does our patient need it? So the indications are very clear. If your PO2 is less than 7.3 kilopascals without any complications, or it's less than 8 with peripheral edema, polycythemia, or pulmonary hypertension. So such patients have clear benefit in terms of morbidity and mortality if you put them on long-term oxygen therapy. And I'm happy to say that the Sri Lanka College of Pulmonologists, with the leadership of one of our past presidents, Dr. Ravini Karunatilaka, have initiated home oxygen services in multiple hospitals. So we have the facility, and the patient would get a free oxygen concentrator to carry home. So if they can pay the electricity bill, obviously, but then so we have that facility. So please make use of it. And then does our patient need NIV? Because to prevent another admission, we might need to put our patient on home NIV. We have so many examples of patients admitting every month for due to respiratory failure, but then when we put them on NIV, they have been off admission for years. So they came to see me after one whole year because the machine started failing, not because of they had an admission. So they have been going to the clinics regularly, taking the medicine, but came to see me because the machine was non-functioning only. So there are indications for NIV in COPD, not only COPD, any type 2 respiratory failure needing multiple admissions with NIV. We can put them on home NIV starting at night time, which will help them to have a better quality of life and survival improvement as well, as clearly shown by this trial. So you can see that in this trial, the home oxygen plus home NIV has better admission-free survival than home oxygen alone, right? The hot HMV trial showed that there is an increased time to readmission or death by 90 days by using home NIV together with oxygen therapy. And it reduces the likelihood of readmission or death by over 50%. And here we can see that the hazard ratio, right? So there is, so I can't see the slide actually. So here the median time to readmission or death is reduced, and we need the number needed to treat. So the number needed to treat is very clear. Here it's only 6 patients needed to be treated to prevent 1 readmission or 1 death within a year. So it is very important for us to consider these modalities, and in near future we will be able to offer the home NIV services to these patients as well, free of charge through the government, and the college is working on that, and I think we are in the final steps, maybe in 1 month before we are able to start this. Okay, so the other thing I want to say is starting home NIV, putting the patient on a machine is not just enough. We need to see whether we have maintained or we have gained a reduction in the PCO2 level by at least 20% or to achieve normocapnia. Especially we'll have to relieve nocturnal hypercapnia. So those are the people who have shown a clear benefit in mortality, not the people who are being treated halfway with the NIV treatment. So in summary, in our hypoxemic respiratory failure, nasal high flow therapy is superior to conventional oxygen therapy in the failing patient. Use of nasal high flow over NIV in pneumonia is recommended. So we recommend nasal high flow in pneumonia, not NIV, and one reason is why the not giving lung protective ventilation in NIV, so we might be causing some ventilator associated trauma in our patients as well. So in the hypercapnic respiratory failure patients, bi-level ventilation is very important. Mask interface is very important. I have seen patients with masks. The mask is leaking. There is a plaster on the jaw covering the half of the mask and half of the patient face. Elastoplaster, I don't know how they are going to take it off. This is a real thing I have seen in one of the hospitals. So we need to make sure that the mask interface is properly applied to a patient, and also use the clinical assessment. Look at the work of breathing rather than just looking at the numbers of saturation only in a patient. Okay, so with that, the symposium is now open for discussions, and I would invite you all to ask questions from our eminent speakers. So to start with the first question, I would just like to, so we were talking about a lot of NIV, but how are we going to start on high flow nasal oxygen therapy? What is the initial settings we would consider? Can I ask Dr. Afla about that?
So patient selection is very important, and just because you're we discussed the numbers, we think that patient will be benefited from high flow nasal oxygen. It's not in such an example, like if the patient has bilobar or lot of lung infiltrates and hypoxemic, in those patients trying with high flow nasal oxygen, yes, maybe as a bridging, but may have high chance of failure. So the patient selection, if once a patient is selected according to the clinical criteria, basically we are just looking at the flow rate and the oxygenation. Here what is important here is the oxygenation. So in this case, if your oxygenation, if the PaO2 is less than 50, so oxygenation FiO2 of less than more than 40 is indicated. And if you are, then in that case the flow rate has to be more than 40, and up to 60 to 70 is appropriate. And then if we need it, and within specific time duration, we should monitor the saturation in addition to the workup breathing and respiratory rate to whether it increase the FiO2 along with the flow rate. Because the flow rate, if we have gone up to 60, I think the timing to increase the FiO2 up to 60 will determine whether there is a chance of failure.
Okay. So, Dr. Anushka, regarding this NIV, now you all are all very familiar with dual limb NIV settings, and but we are, as respiratory physicians in our HDU, we have single limb NIVs. So, can you tell about the challenges we would have and the mishaps done by the people when they are going to put on NIV?
Yeah, so first of all, we are very lucky to have dual limb NIV. I'm sorry about you guys. But so one limb, these are for domestic use. So you can use it. There's no issue with it. So the physiology behind it is there is a pressure support given by the machine, and it comes through the limb, and the patient breathes because of that support that is given. So there's no oxygen coming through. It's just the air that is being entrained from the machine. So if you need to give oxygen, you have to connect it separately, right? And then the exhalation goes through the 3 holes. So there should be an expiratory port. So that will go out through that. And so the one thing with NIV is you expect to have that pressure support, the high pressure as well as the low pressure, which is a bit lost through that expiratory ports that you have. So it might not be as effective as the 2-limb system where there are no kind of leaks. There is an inspiratory valve to the inspiratory limb. So during inspiration that is open, air will come and it will go into the lung. And during the expiratory valve is closed. So there's nowhere else to go. It just goes into the lung. And during expiration, the expiratory valve opens and the inspiratory valve closes and it goes out. That's how it's, so there's no rebreathing as such that occurs as well. Here it's the same kind of gas that goes out and comes in. So there's an element of rebreathing as also. But apart from that, if in COPD, what you expect is to increase the minute ventilation because there's a lot of dead space ventilation that's going on. That is the reason for the increase in carbon dioxide. But you can achieve that amount of tidal volume, and it seems to be working. You are doing home ventilation with NIV. So it seems to be working. Other than that, the challenges would be, I think...
So, sorry to interrupt. It's not, it seems to be working, it is working.
It is working. Sorry. It is working, it is working. No conflicts with the respiratory physicians. They are very good friends with us. Sorry. Yes. Yeah, it's working. And any other challenges that you have faced that you might want to, like, I have not experienced at home?
Yeah. The one thing is then in the COVID era, we had to switch to the non-ventilated masks from the vented mask. So one mistake what we have been doing is, so we have in the sense we have picked up is that sometimes they use the mask without a leak port. So without the leak port, the patient can't breathe out. So the patient is suffocating. Sometimes our patient will not tolerate the NIV, not sometimes they will definitely not tolerate the NIV, and we will not know why they are not tolerating unless we know what we are doing. Not in Verisera. Not in Verisera, obviously, because with COVID, lot of medical units started using NIV, and that was number one problem. And then where to fix the filter was another challenge in COVID. Where to fix the filter, whether is it before or after. So those are the various challenges they were facing.
One point to add about this, because now we see the increased number of use of NIV in general medical wards. So I personally feel that we all heard about the benefit of NIV. But remember, the inappropriate or incorrect way of use of NIV will cause harm. So one thing when we practice is to avoid harm. So if we are not sure, and if we don't use properly and incorrectly, or if you have not monitored properly, it can cause harm.
Yeah, I think I can remember Dr. Amita Fernando said that we went to see one patient who was in IV. What he did first, so what he did was remove the mask, and he said, Dr. Budu Bavatpen.
Mask.
I asked them, but they didn't remove it. My style was telling.
So basically, inappropriate.
Can I add something for this? Hypoxemic respiratory failure cannot be treated with these domestic masks. So pneumonia, severe pneumonia, ARDS cannot be put on single limb machines. This is because, do you know the maximum flow of oxygen that can be given through this? It's how much? It's 15 liters because you connect it to the wall oxygen. Do you know how much of flow can be given through the high flow? 60 liters. So when you're in hypoxic respiratory, if you go to the pathophysiology, the hypoxia causes increased respiratory drive. As a result, the patient will take deep breaths in, as I told, increased tidal volumes. It's because he's starving for oxygen and he needs oxygen. Now, when you're connecting these patients to this single limb ventilator and giving 15 liters, that is not going to be adequate. He's taking up about, during that inspiration, the flow rates will go up to about 60 liters per minute within that inspiratory time, because they're dragging the air so forcefully, but we are only giving oxygen of 15 liters. So we are actually causing more, kind of a oxygen starvation by putting them on these machines. So domestic machines are not for hypoxic respiratory failures. But when you put them on the ventilator, the actual ventilator that we have in the ICUs, they can go up to 60 liters, even 70 liters, and the high flow can go up to that level. So for hypoxic respiratory failure, the best thing to do in the ward setting, I would say, is high flow, rather than going for these domestic machines.
Yes, that's a very common scenario that we come across.
Yes, hospital grade machine.
Yeah, so we checked in those machines, like, with the 15 liters maximum, you can get 35 to 40% of FiO2. Even if you go up to 70 liter flow meter, the maximum you can get is 50 to 55%. So in a patient who was on a 60% Venturi, now they say saturation is not picking up, then they put a non-rebreather. Still the saturation is not picking up, but they put that machine. So you see that the saturation drastically dropping because the patient is hypoxic. You are providing the support, but you are not providing enough oxygen. So that's the thing that commonly we see from the ward requests.
So, but the only thing is that I accept with your argument on the hypoxemic respiratory failure, but then we have this recovery RS study which was performed in, which was considered one of the world's largest study on hypoxemic respiratory failure, where they have studied the CPAP therapy, that is not it's a non-invasive positive pressure ventilation therapy versus high flow nasal oxygen therapy and conventional oxygen therapy. So when they found when they compare the conventional oxygen therapy with high flow nasal oxygen, so I totally agree for the pneumonia that is based on the flow early study, the preferred choice is high flow nasal oxygen therapy. But what they found is that when they compare the high flow nasal oxygen therapy with the conventional oxygen therapy, and the conventional oxygen therapy, it is equal. It is not conventional oxygen therapy. The high flow nasal oxygen therapy is not superior to conventional oxygen therapy in preventing intubations or improving the survival. But when these two modalities were compared with the CPAP therapy, they have found it reduces the need for intubation, mechanical ventilation, intubation and mechanical ventilation, and improve the survival. But I don't know for why. So the Floral is the only single study which is the only large study, and based on that, these extrapolations are made. So I understand the theory behind your explanations, but this is what
there are machines who can give proper NIV. You can go up to 100%. You can go up to 100% FiO2 with a proper NIV machine, yes.
But the thing is, the machines they used in that study, it's not that ResMed what the standard 150. They,
are you sure?
yeah,
Because most of the hospitals in
hospitals.
UK, most of the hospitals in UK. So this was a study which was done in UK. So it's
They
the
have
most
the
of the
V60 NIV machines.
V60 had my machine, V60, and plus most of the patients in that study was post-operative patients.
no, this is COVID.
In
This
the
is
COVID.
No, this is COVID pneumonia. So most of the hospitals on the ward-based NIV, they use this standalone NIV device. The most of the devices in the both trust where I work, they use the standalone NIV device with ResMed.
So they can probably deliver more oxygen. With the COVID, it's a hypoxic.
No, the standalone is the one that we are using as well. So
Which one?
so as we said, as Sir said, so
Which one you're talking?
So the standalone ResMed Stella 150 and 100.
Yeah.
So as you said, I was also managing these COVID patients in the ward. So when we were using the 25-liter regulator, we can go up to 60% FiO2.
No.
But when we calculated, it came to about 50. We did
Yes, so,
Yes.
so 15 liter, yes. Around 15 liter, 50.
70 liter.
Yeah, 25 liter, it goes up to 60. So that we,
No,
we
you
can
can
have a
check on
gadget to
yourself.
measure that.
We have the machine, so you can check on yourself. We checked it was even with the 70 liter, because that's why they don't provide the FiO2, the measurements. So those are based for home NIV. Home NIV means they need just the support. They don't require much of oxygen. But if you're going for a hypoxic failure, who is on 60% non-rebreather, they crash because you can't provide enough oxygen.
Then again, that if you are using an NIV, so the lung safe studies, that so for example, if you are using FiO2 of 50 to achieve a saturation of 92, so the PEF ratio would be definitely below 100, isn't it? So if you say, so if you're using a 60% FiO2 to aim a saturation of 92%, the PaO2 would be approximately 60, isn't it? So the PEF ratio is closer to 100%. The lung safe study, the NIV shouldn't be continued if the PEF ratio is less than 150, isn't it? So those patients needs to be intubated, isn't it?
Yeah, definitely. The hypoxic, that's why I said the hypoxic respiratory failure, the place of NIV is limited. If you want to intubate, yes, you can put them in NIV and then you reoxygenate.
Next time.
Or if you want to transfer the patient, because you can't transfer the patient on high flow from
Next
the
one.
ICU to
Next one.
the ICU. Then of course you can use the NIV. But if escalating therapy, there is not.
So my argument is that we can't expect to deliver an FiO2 beyond 60%. There is no point of doing that.
Yeah.
So
In the interest of time, I'll tell you.
Having a device to provide a more FiO2 more than 60% wouldn't be beneficial.
No, the other one has a point, Dilshan. You know, because the studies, everything came with this COVID, no, because the oxygen demand was very high in those patients. Now, but when they did this type 1 respiratory failure, normal community-acquired pneumonia patients, not that, because we always felt that COVID patients, oxygen demand is very high. Even sometimes you see little infiltrations, but the oxygen demand is very high, isn't it? So tidal one is also very high. So, but now when I read this article, which was published in 21, so recommendation for NIV for community acquired pneumonia, I felt little more than the previous article. I'm sure with time, I think it won't be superior to high flow, but at least will be equal.
But it probably depends on the community that you study, yes, and the devices that you use.
So, and my question is from Dr. Anushka. This is regarding the concept of the PCILI. The PCILI, the patient self-inflicted lung injury. So it came in a big way during the COVID pandemics. But however, later on it is believed it is just a theoretical perception. So what are your thoughts? Because that in the during the COVID pandemic, that when we were, some of the patients who were connected to the NIV, so they were having a huge tidal volume. So some patients I have seen on 900, 1,200 tidal volume. But so that is during this when they develop the cytokine storm. But they calm down because since we don't have enough ventilators and ICU bed, we manage them on the NIV. So is it based on the concept of the lung protective ventilation? So is it only for ARDS or all the patients with very high tidal lung pathology, or is it specific for ARDS?
It's for hypoxic respiratory failures. So in COVID, it's not ARDS, it's actually pneumonia that caused it. So for any patient who has high tidal volumes, more than 8 ml per kg, what happens is it causes very negative intrathoracic pressure and a negative alveolar pressure. And as a result, they drag in a lot of tidal volume, that is to take up that oxygen that they need. And what this causes is, it causes strain on the alveolar membrane. And theoretically, as you said, that would cause even ventilator-induced lung injury. It's causing strain on the alveolar membrane. When it's stretched, it causes increased interleukins to be formed, and that causes more damage. And also, apart from that, the hydrostatic pressure in the capillaries will, because there's negative pressure in the alveolar, the hydrostatic pressure is now able to push the capillary water inside the alveolar. So there will be more water inside the lung. So that will also get aggravated. Now on top of that, when we start NIV, now you didn't ask about NIV, but what I'm telling is, now the patient is generating a large negative pressure, so it's taking up a large tidal volume. On top of that, we are giving a positive pressure from the other end. So that will cause, if it was initially 8 ml, now it will become 9 ml. That's the main reason why they actually went against NIV at that point. But again, these are all theoretical. And that actually led to the recommendation for saying that high flow came a little bit, better than non-invasive in hypoxic respiratory failures. Your question is, about PCD. So that's the mechanism of PCD that occurs in any type of hypoxic respiratory failure. The hypoxia is strong enough to cause that patient to breathe that hard.
So that this hypothesis has been postulated initially by Gattioni, but subsequently there are several articles debating against that concept, because they only say that this lung protective ventilation, and so because in which case we had to just to achieve the target tidal volume, irrespective of the FiO2 requirement, you have to intubate a large number of patients, isn't it? And even if you are intubating, then you have to paralyze and ventilate those patients, isn't it? So that's a huge difficulty, especially during the pandemic.
When the COVID came up, we thought of not intubating initially, but then came like kind of a wave. We intubate them early. We kind of learned and we evolved through the pandemic, and lots of theories came up, and then they were broken up again. So that's kind of medicine that comes up. So, but the next pandemic, everything will be different. But currently, for any type of ventilation, when we do invasive ventilation, we recommend, low volume tidal ventilation. Up to now, I don't think that has changed, Advan. We are still doing that.
Okay, thank you. So I'm interrupting you all during a very intensive and very interesting discussion, but in the interest of time, we need to wind up the session. So thank you very much for your active participation, and you all can ask questions from the speakers during the lunch break. Okay, thank you very much.
Thank you once again to our speakers, moderator and guests of the audience for that very interactive discussion on enhanced respiratory support. To hand out the tokens of appreciation for the speakers, I warmly invite the President of the Sri Lanka College of Pulmonologists, Dr. Niranjan Disanayake. Dr. Afla Sadiqeen. Dr. Anushka Mudalige. And Dr. Dilshan Priyankara. I would also like to invite our moderator, Dr. Dilesha Vadasinghe, to receive her token of appreciation. Thank you, sir. That concludes the end of the 3 symposia planned for today. We once again thank all our panelists for sharing their knowledge and expertise on respiratory critical care today.